Today we're going to talk about TFI. It's a new imaging modality for examining the retinal pigment epithelium with microscopic resolution. TFI, it stands for transcleral flood illumination. It is an optional module that we added to the RTX1 AO retinal camera. And with this module, the device illuminates the retina through the sclera. For the roundtable today, we have invited the first users of this new modality, 3 ophthalmologists from the National Hospital in Paris, who very kindly agreed to share their experience and insight.
So today we are very glad to have with us first Michel Paques, who is professor of ophthalmology at the National Hospital in Paris. He pioneered the development and the use of AO retinal imaging in a wide number of diseases, including for AMD and the progression of geographic atrophy. We also have with us Dr. Kiyoko Gocho, who is an ophthalmologist and a researcher in Michel's team. And Dr. Gocho also works at the Kobe Eye Center in Japan. Regarding TFI, she is the first doctor who tested the RTX1 with TFI to examine patients in clinical settings. And our third guest is Michel Borella. So Dr. Borella is also an ophthalmologist and researcher in Eye Hospital in Paris. And for her PhD, she is currently studying AMD progression mechanisms with imaging as well as histology. So now I will address our 3 guests to talk about TFI. As Nicolas said in introduction, it is a new module that makes it possible to view the RPE with RTX1. So first, Michel, why imaging the RPE is so important?
Well, imaging the RPE is important just because it's the cell that without which the photoreceptor cannot work. So without RPE, you're blind, of course. And it's still a layer very difficult to image. You see by OCT uniformly hyperreflective line, but no real details of what's actually happening of the disease of the RPE at the cellular level at least. And we know that phenomenon such as AMD, for instance, occur at the cellular level, at the atrophic form in particular. And we're really frustrated not to being able to observe the behavior of individual RPE cells as with the same quality we can with individual viewing of photoreceptors with the RTX1 camera. That's why it was really something missing for ophthalmological examination of our patients.
Thank you, Michel. And so now I want to ask Dr. Gocho, what do you see on those TFI images and how does it compare with the usual adaptive optics images?
Yes. So with the TFI, with a normal RTX1, normally we see the photoreceptors, and with the TFI, so the RTX1 include an additional illumination mode like transcleral, which reveals the deep layer of the retina. So with the TFI, we illuminated the retina by oblique light through the sclera. So in this case, so we see the normal standard image where we see the photoreceptors. Actually, we can see that behind the photoreceptor, we can see the other structure looks like a honeycomb and like a dark center and a brighter outside. So it really looks like RPE cells.
And so how do you know that what we see is actually the RPE cells?
Yes, so we thought, so this is the image of the TFI image, and with the Elena Goffas, our researcher at the also, so we worked on to compare with the autofluorescence AOSLO, the AF AOSLO, with the exactly same area of the same retina. So because this is the autofluorescence AOSLO image, and also our team already published the autofluorescent imaging of the RPE cells. So by the Kate Brave and the Michel. So we know this image is the RP cells. So we can see exactly the same cells and this in the same place. So we think what we see in the mosaic structure is the RPE. And the acquisition time of the TFI is around 6 seconds. But the autofluorescent is at least it needs 1 minute. So we think that still we can see the RP cells by the TFI. And also we measure the cell density and the intercell spacing of the RPE. So, and it was very good, the agreement with the literatures.
Okay, so these images are really interesting. Thank you very much. And now we want to ask Michel more about, to tell us more about the medical interest of this new modality in pathology.
Okay, so I've been interested in disease such as geographic atrophy for some time now. The question I asked myself was, how does geographic atrophy progresses over time? And this is an example of the animation of some patient that we followed up for several years. And by carefully realigning the images, we can observe some dynamic features associated with the geographic atrophy progression. And in particular, I hope you see my mouse. There's these white spots here you see in the margin of the geographic atrophy, which seems to evolve over time. And we're interested in understanding the synchrony between this motion and progression of atrophy, because this motion seems to proceed to occur before atrophy actually progresses. And so understanding the mechanism linking these two processes is probably of high interest. And with the RTX1 and with Kiyoko Gocho, we've been studying the distribution of melanin pigments in margin of GA for some time. And you see here an illustration of what we can see with the RTX1. You see, this is an area of atrophy. It's a close-up of this area here. This is atrophy here. And you see these dark spots, which are most likely melanin-loaded cells, MLCs. And this is a histology by the team of Gocho showing the similar size, the melanin-loaded cell that you can see here. So we suspect that the scene here is the same as what we see here. And the interest of the RTX1 camera is to enable a very close follow-up and detection of progression. Here, within 1 month, we can detect progression of atrophy. But what's even more interesting for understanding the mechanism is the fact that this motion can also be detected in the MLCs, in pigment spot away from the atrophy. So we're very interested in understanding, having better images of this pigment dispersion. And this is another illustration. A similar distribution of pigment can be better understood in 3 dimensions using OCT, which has a lower resolution on the XY axis, but a higher resolution in the Z axis. So both approaches are necessary to obtain a better viewing of the pigment distribution. So here you see en face OCTs and here transverse imaging, and you can document very nicely the distribution of pigment, although these smallest dots here are difficult to distinguish from the background noise. And so this is another illustration of the dynamics of this pigment. So there's a complex dynamics of pigment that we're trying to understand. We've made some significant progress. Here, look at this case here, the progression of atrophy, and this area here within the rectangle is seen here by adaptive optics imaging. Sorry, it's not looping. It's supposed to be looping here. So you see the growth of the atrophy, and the pigment are these dark spots here, and you see some are moving, some are static. And this recapitulates the motion of pigment. These are static pigment representing this one here. And this 4 images are corresponding to 4 different time points showing the propagation of this pigment disturbance. So we expect that using a TFI, we'll have a better image of the pigment distribution. And indeed, it is a case. You see here a case in which you see with the RTX1, showing here the fovea, which is still preserved, and atrophy on both sides of the fovea. And with TFI, you have a much better viewing of the pigment distribution that you see here, even the pigment distribution within the residual RPE. And that, I think, is the most interesting feature. Even if it's not visible by the RTX1, you can detect pigment redistribution with the TFI. And this is of a high interest to better understand the mechanism of the disease. Here, another illustration, the same case. This is another case here showing atrophy here with the RTX1. And you see here the pigment is visible by the RTX1, but it's have a much higher resolution signal using the TFI. And also, interestingly, the atrophy seems to disappear in the TFI, so it really filters out the distribution of the melanin spot, which is for us interesting for understanding dynamic processes associated with atrophy progression.
Thank you very much. So now to understand better those images, I want to ask Issei. You have been studying the RPE and eyes with AMD using histology. What does it tell us about what those TFI images show?
So, yeah, the interest of TFI imaging and in vivo imaging is that we can image the patient along the time, but we cannot know exactly what kind of cells we look at with the TFI. So we have some cues with what showed Dr. Gocho just before. So for example, when we have an image of the healthy eye, we can really compare with the ex vivo imaging. So with that ex vivo imaging, we use human donor eyes. So this one is a healthy eyes, and we can map all the pigment redistribution using Nomaski optics, and also all the cell border with confocal microscopy with immunolabeling. So this is very interesting for the healthy eyes, but the healthy eyes, we know already the pathology on the TFI. What is interesting is also the pathology. So when you have some kind of an image like this, we can see that there is pigment dispersion and there is pigment dynamic dispersion along the time, but we can ask what is that kind of pigment and what can we see around it. And in fact, when we see on the classical OCT, there is both pigment located inside the retina and pigment located at the level of the RPE. So we can distinguish both of them. And in histology, what is interesting, we can separate both layers and study the RPE layer and the retina layer apart. So how does it look? When you have a hyperreflective foci, which is located inside the retina, so you can see it with the Nomaski optics, and you can see that, in fact, so the green labeling shows the macrophage-derived cells, and the red labeling shows the RPE cells. So you can see that there is some fragment of RPE cells and many macrophage-like cells. And so that the HRF, so there is two hypotheses about that, is that either it's microglia or monocyte-derived cells that just uptake RPE cells or other. But so we can see that there is monocytes and macrophages inside the retina with pigment inside them. And when you focalize on the RPE, you can just take the RPE layer, and you can see that you can do all the classical clinical imaging on it to compare the most with the highest precision with what you can see in patients. And what you see is that this is a GA patient, so an AMD patient with GA. And here you can see is the GA because there is no RPE cells anymore. And on the RPE layer that still remain, there's a lot of pigment redistribution inside the RPE cells. Like so, those kind of very zones of highly pigmented cells. When you're doing the confocal microscopy with the immunolabeling, you can have really those cells, and you can see that it's very, very enlarged cells located inside the layer of the RPE layer. When you focus on this, you can see even better those cells that are very dysmorphic, and that correlate with pigment redistribution. So this is very interesting because the problem is that we have something that at one point, because it's human donor eyes, but the interest of TFI is that we can follow those patients and try to understand what's going on with those points of hyperpigmentation.
Thank you very much. So after seeing such images and all the comments, I'm sure that the audience would like to hear a bit about the practical aspects. So Kiyoko, can you explain a little bit the acquisition procedure to obtain those TFI images?
Yes, it is very similar to use the Retix one. But the acquisition time is normal Retix one need 2 seconds, but the TFI need around 6 seconds. So, and the light source, the light projectors is it has to go through the sclera. There is a bit close to the eye, but it is also removable because as it is connected by the magnet. So when we don't use the Retix TFI mode, we can remove it. And also now we can take at the exactly same time TFI and the Retix one. So we can see the image and the retina with the same mode, the same place, the same time from the two modes. So it's very convenient to compare with the Retix one image and the TFI. So as we know, the autofluorescence AOSLO can see the RP cells. It takes more than 1 minute, but the TFI is around 6 minutes and we can visualize the RP cells. So it's very interesting. And also for the MD patient, we have no problem to use the TFI. So far, it's acceptable for the patient, I think.
Thank you, Kiyoko. There are questions from the audience. So one question is TFI a non-contact imaging procedure?
Yes, it's non-contact.
And were you able, so maybe this is a question to the three of you, were you able to see the hexagonal shape of the RPE cells?
Maybe Ise knows the better.
Sorry, I didn't get really the.
Were you able to see the hexagonal shape of the RPE cells?
Of individual RPE cells.
I guess it is the question, yes.
Oh, so Kiyoko maybe have better.
Yeah, in the healthy cases, we can see it, and yes, in the retina.
I'll show an image. If
it's
share my screen.
We can see the hexagonal arrangements of the cell mosaic.
There it is on the. You have another image. You have another image. So this is a typical image that we can see. These eyes. So the individual cells are not always detectable as finely as by histology, of course. You can see the global arrangement and density of cells rather than the individual shapes.
Another question is why do they appear? Sorry. Some as black and the others as white. Sorry for that.
Why do they appear some as black other than the white? They should use ICG. No, we don't use ICG. And
sorry.
I don't know why there is a difference, but I think it's related with the dry, MD case, which there is, as Ise explained, there is some the pigment, this expression. So maybe Michel can explain it a bit.
Yeah, they were not exactly sure how the image itself is generated. Maybe it may be a transillumination after bouncing back from the sclera, or a direct mix of reflectance from the retina and reflectance from the sclera. So maybe the thickness of cord also influences the image. So we don't have the perfect explanation yet to understand how the image is generated, for sure.
And I think there was also a question about some cells appearing black and some cells appearing white. So I think that there are some cells we can see the nuclei also. So we see mostly like white coming through the nuclei, and some cells are just loaded with more pigment. So this we can see in histology.
Another question about the, and did you use ICG?
No.
And another question is there any limitation for the area of the retina that is imaged?
Kiyoko, maybe?
Yeah, I usually use the same as the reticular image. So I don't know any limitation for area. What does that mean? But usually where we can take the reticular image, we can take the RP cells.
Now, the field of view is roughly
the
same as the distance between the fovea and the optic nerve, so over 30, 60 degree.
Yeah, 30 by 40, 40, 30 around, really. Yes.
But it's theoretically feasible to go further away, but there is no internal fixation, so it's going farther, or it depends on the dilation, because the size of the beam is larger than that of the OCT. That's why we cannot go as far as with the OCT.
I haven't tried it very far, like using the alpha fixation mode. So maybe I should try, but I haven't yet.
Okay, and there is another question. What about lipofuscin?
Well, we don't think that lipofuscin accumulation is detectable using the RTX1 and not the TFI, but that remains to be demonstrated. What we see is either melanin or melanin lipofuscin rather than lipofuscin alone.
Okay, and there are several other questions. So can you quantify melanin pigment?
The density of melanin? Very good question. Not really. I think anyway, to my knowledge, nothing is really reliably quantifiable in terms of intensity of reflectance. That is the same applies for the TFI image.
And okay, and the rest of the question was, if yes, have you observed variation of pigment with light exposure after dark adaptation or photo bleaching, for example?
We're working on that currently. We have no data.
What software can you use? Can you use the standard RTX1 tools to quantify RPE cell number density? So maybe I can answer that. So we are preparing a tool to facilitate the quantitative analysis of the, so not of the density, but of the geometry of the RPE cell mosaic. Next question is, how reliably does TFI detect RP cells in AMD patients? Is there any head-to-head comparison with autofluorescent RP imaging in terms of RP detection in the same AMD patients?
That's a very difficult question. In AMD patients, every cell imaging that we can do in normal eyes usually do not apply to AMD patients. I'm talking about the area with persistent RPE, of course. And with the RTX1 photoreceptor has become very difficult to distinguish. And the same applies for RPE, and it's not restricted to the TFI image, even by adaptive optics, SLO, autofluorescence, RPE are very difficult to distinguish once there is a RPE disease. So showing that there is a diffuse RPE disease in geographic atrophy for sure. We don't have yet data to show in AMD patients to show how the mosaic of RPE is altered. This is something that interesting by itself, because it shows that there is a loss of contrast, of intercellular contrast, very early in these diseases.
Yes, and the question was about the reliability. So this will take probably more studies to assess the reliability in AMD.
Yes.
Sorry, I just want to add that, but it's very interesting to document early pigment redistribution, loss, death of RPEs, provokes dispersion of melanin granules. And these are very easy to detect using the RTX1, the TFI.
So thank you. So AMD with GA seems to be the popular application, but which other pathologies do you see could benefit in a clinical setting from TFI?
Oh,
Sure. Yes, I tried with some IRDs like RPE and cone dystrophy, and very long. The other conference I showed some cases. So I think for IRD also it's very interesting, but we haven't done the real study yet.
Yeah, we're discovering the technology. We built up some protocols, and although the AMD seems to be the first application, as Kiyoko said, I think we have to extend the exploration of different diseases. And any disease with pigment alteration, I think, will be the first candidate. Maybe choroidal disease could be also something to look at. And of course, evolution of myopia, that could be interesting to see if how does the individual RPE cells, even in the absence of damage to the RPE, understanding the evolution of myopia could be something interesting to look at with the TFI.
Is it possible to count the pigments in disease cases? It's another question about quantification.
Well, I should ask that question to you, Nicolas, because
well, I would say not yet, because now what we are implementing is the most possible efficient procedure to get RPE images that are aligned with cone images, and for the quantification, our ambition is to be able to quantify the distribution of RPE cells when the images the quality of images are good enough. So when the cells are not completely damaged or do not disappear.
Maybe we can probably we can quantify the numbers of HRFs in GA, for instance. That could be feasible because it's quite large, and we can detect probably nascent HRFs as well at very early stage. So that could be a first application of quantification using the TFI.
What were the difficulties you faced in terms of when imaging patients? Was the clarity of media and the other patient factors like dyskinesia, were the limitations for imaging?
Yes, it's same as the Redix one, but also we need a little bit longer time. So we need a good concentration of the patient with good fixation of the patient. Yes, like that.
And a good pupil dilation as well. That's
yeah, we need a pupil dilation usually.
Okay. Now it's already time to wrap up. And there are still questions that we have not answered, so we will do it by email. I want to thank you, the panelists, very much, and thank you, Marine, and thank you all the attendees for asking many questions. So we will follow up soon by email with you. Goodbye, everybody. Thank you.